All right, good morning, everyone. Why don't we go ahead and get started? Looks like winter has finally hit. We have two great talks this morning. The first is by Dr. Fred Pieracci, who's interim chief of surgery at Denver Health and professor of surgery. His talk is a decade of surgical stabilization of rib fractures at Denver Health. Did the hype pan out? I suspect it has. By brief introduction, Dr. Pieracci received his undergraduate and medical school education at the University of Pennsylvania. He did a master's of public health at Columbia University, his general surgery training at Cornell, and then came to Denver to do his tax fellowship at the Denver Health and CU program. So he's been on faculty for the past 10 years, has really built a strong program in chest wall injury, and has held multiple leadership positions in societies that deal with chest wall injury. For example, he was president of the Chest Wall Injury Society, and he has actually helped to found several others. He is very academically productive, has over 112 peer-reviewed publications, goes all over the world to speak on chest wall injury, is known as a great teacher, and has a very busy clinical practice at Denver Health. And with that, I'd like to turn it over to you, Fred. Dr. Pieracci, please.
Okay, great. Thanks very much, Dr. Schulich, for that kind introduction, and good morning, everyone. It is always a pleasure and a privilege to speak at Grand Rounds, and I appreciate everyone tuning in. So for the next 20 minutes or so, what I'd like to do is to review our experience with rib fixation here at Denver Health over the last decade, and basically focus in on where we are with the indications for the procedure and who we think benefits most from it. And I'd like to do that through the lens of reviewing some of the excellent research that has been done by our trainees, our med students, residents, fellows, and APPs, to help expand our knowledge on this particular operation. So I have no disclosures. Before I get started, I need to acknowledge that all of this work and my personal career would not have been possible with my two mentors listed here. The first one is Gene Moore, of course, who needs no introduction. Our trauma center is named after him. And Dr. Moore's vision and latitude with me as I was a fellow and junior attending allowed me the freedom to explore my interest in chest wall injury and help build this program. And then John Mitchell, I had the privilege of spending 6 months with as a second-year trauma fellow, and he really taught me two main things. The first thing was a meticulous thoracic technique with chest operations, and the second is a dry, sarcastic wit that I try to use every day when I can. So thank you to both of my mentors. I think trauma surgeons will agree that over the last 10 to 20 years, trauma surgery has, in general, become more non-operative. And I think there's a risk of trauma surgeons and trainees losing some of their operative skills. And I'm happy to report that over the last, 5 years or so, there have been three main operations that are promising, both because they help patients survival and morbidity, but also because they help get us trauma surgeons back into the operating room. So the first one has been pre-peritoneal pelvic packing, and a lot of the research on that has been led by Dr. Clay Berlew here at Denver Health. The second one is REBOA, which has been led over here at least by Gene Moore and Ryan Lawless. And then the third one is rib fixation. And just to give you an idea of how frequent an operation that has become for trauma surgeons here at Denver Health, this year will surpass trauma laparotomy as the most frequent operation that we do over here at Denver Health. And fortunately, the research on this operation has mirrored the increased incidence of performing it. This is just a quick PubMed summary if you type in surgical stabilization of rib fractures, and you can see there's really been an explosion of data into this operation, which is a good thing because it's our job to base our indications on evidence. So the concept of fixing ribs is an orthopedic one, and the basic idea is that when a bone is broken, you want to reduce and fix it so that it heals. And the ribs, of course, have the added consideration of being integral to respiration. So if your ribs hurt because they're broken, you don't take deep breaths and then you get pneumonia and get intubated and so forth. So people realized this hundreds of years ago and tried all kinds of methods of fixating the chest wall, ranging from negative external pressure using an iron lung to various K-wires and pulley systems. And I have to say that the explosion of interest in rib fixation in the modern time has been due in some part to developments in industry and with the tools that we need to perform the operation. And of course, no one system has ever been shown to be superior to another. But just to give you an idea of where we've come relative to that previous slide, you can see that we have all kinds of options now that are tailored specifically to certain types of rib fractures, as opposed to kind of MacGyvering fibular or maxilla or mandible plates to work on ribs. So we have pre-contoured plates, we have super thin plates, we have T-shaped plates to fix to the sternum. We even have a pulley system that uses an intrathoracic kind of VATS approach to place the plates on the inside of the ribs. So that's all been great for us as surgeons. So to transition now to modern day indications for rib fixation, I just want to mention that the majority of work early on with rib fixation studied patients with flail chest and mostly clinical flail chest, meaning paradoxical respiration observed on physical exam. And the early data was very favorable for rib fixation in this clinical scenario. And there are currently two expert panel recommendations, both of which give a high grade recommendation of rib fixation in patients with flail chest. And I refer you to them here if you want some more details on that. What I wanted to focus in on, however, are non-flail fracture patterns, because if you look at the breakdown of flail versus non-flail in our trauma patients, it's about 95% non-flail and 5% flail. So if we really want to make an impact on the most patients who are suffering from severe chest wall injury, we really should concentrate on the non-flail fracture patterns. And you can see here in this chest x-ray example that even though in general non-flail is less severe than flail chest, you can certainly still have severe disruption of the chest wall that then can be mitigated by fixation. So we actually quantified what's going on in terms of rib fixation in flail chest versus non-flail chest patients. We queried the National Trauma Database and presented this a few years ago at the Western Trauma, and basically showed that at that time, there were really no data to support rib fixation in non-flail fracture patterns. However, the vast majority of rib fixation was happening in patients without flail chest, or at least a National Trauma Database diagnosis of flail chest. And then also concerning was the exponential growth in rib fixation in non-flail patients, which was most pronounced at lower level trauma centers. So we had a surgery that was going on without a lot of great data to support it, and predominantly at non-academic centers who weren't really studying it. So we saw this as a cause for concern. So when we thought about how we could study the benefit of rib fixation in non-flail rib fracture patterns, it was a bit daunting at first because rib fractures are so diverse. You can see here 4 examples of rib fracture patterns. The upper left shows an anterior displaced fracture after CPR. The upper left shows a severe crush injury on the left. There are some posterior subscapular fractures on the lower left, which are tough to get at surgically, and then kind of more run-of-the-mill lateral fractures shown at the bottom right. So in addition to all of these radiographic patterns, probably more importantly are the different fracture phenotypes that we see. And what do I mean by that? Well, I think we've all encountered this situation where you have a CAT scan shown on the left, some posterior lateral displaced fractures. And depending on the patient's underlying physiology, their other associated injuries, you can either have a patient in scenario A who's smiling and sitting up in bed, not requiring any oxygen and ready to go home and has an x-ray that looks normal. Or you can have a patient in scenario B who with the same radiographic fracture pattern is splinting and certainly not smiling. And then when you perform a bronchoscopy on that patient, they've accumulated massive amounts of secretion. So how do we account for the variability in both radiographic fractures and physiologic response to try to study the benefit of rib fixation? So one of the ways that we got at this was to design an objective physiologic score that tried to answer the question, how is a patient doing in response to their rib fractures? Instead of one morning someone saying that their respiratory rate is increased and the next morning saying that their IS is less than 50%. So we tried insofar as possible to make this standardized and objective. And there are a lot of scores out there, so you don't have to hang your hat on this one, but I want to make the point that if you really want to get serious about this, you have to use a score that is the same every single time. So Kim Harden, who's one of our SICU nurse practitioners, spearheaded this study, and we created the SCARF score, which stands for the Sequential Clinical Assessment of Respiratory Function. It's relatively simple in nature. It assigns 1 point to each of 4 variables that are listed there. And so the score ranges from 0 to 4, with 4 being the worst. And we showed in about 100 ICU patients that as your SCARF score increases, you have an exponential increase in your likelihood of pneumonia, prolonged ICU length of stay, and high oxygen requirements. And what's more, the score is dynamic. So you can calculate the score, place local regional anesthesia, recalculate it, report it on rounds every day. And if the score is going up, the patients do worse. So we chose, based on these data, a cutoff of greater than 2, where we consider interventions such as local regional anesthesia or rib fixation. So again, it doesn't really matter which score you use, but you should use a score. Then as a next step, we wanted to design a prospective clinical trial to address the question of, does rib fixation benefit patients without flail chest? And the approach that we took is we conducted a online SurveyMonkey questionnaire that we sent out to members of the Chest Wall Injury Society. And we presented them with various clinical vignettes that varied patient age, degree of traumatic brain injury, and where the fractures were located. And then it also varied the SCARF score. And it asked a simple question, which was, would you offer this patient rib fixation? So you can see in scenario 1, the respondent was asked, in a 40-year-old with no TBI and anterior fractures, and for example, a SCARF score of greater than 2, would you offer rib fixation? And then we made this heat map here, which has each of the 18 scenarios, 1 row each, and then the percentage of respondents who said they would offer rib fixation. And it ranged from very low to very high. But what we were after was the closest to 50%, because that is what we felt was clinical equipoise. So half of the respondents said they would offer it, half of the respondents said they would not. And we found that that was a young patient with no TBI, didn't really matter where the fractures were, and a SCARF score of 2 or greater. So that was the way that we designed the research question to conduct a clinical trial of this. And so here's the trial that we conducted. We had 12 centers spread throughout the country, and we included patients with 3 or more displaced fractures without a flail chest and a SCARF score of 2 or greater. And our primary outcome was a numeric pain score improvement at 2-week follow-up. So we knew we had to pick a different outcome from the flail chest studies, which really looked at things like mortality and intubation, because this was by selection a less severely injured patient population. So what did we find in this trial? We had 110 patients enrolled in it, and we found a couple positive things. So the primary outcome of the numeric pain score was decreased at the 2-week follow-up visit, and you can see that it remained decreased up to 56 days after discharge. That's the graph on the left. There was a trend towards, but a non-significant decrease in the amount of narcotics that were required in the operative group. So despite fewer narcotics, the pain score remained lower. And then we administered a quality of life questionnaire that was also significantly improved in the operative versus the non-operative group. So we felt this was a positive study for rib fixation in non-flail patients. And again, with pulmonary physiologic derangements, certainly not in patients who were doing okay clinically. There was one more finding which I wanted to highlight because I think it's important. So the study was done under highly protocolized operative technique, including a routine VATS of the pleural space with irrigation. And you can imagine that in patients with severe chest wall injury, there's a high incidence of hemothorax. And so we irrigated everyone's chest with 3 liters of warm saline, and we left a chest tube, which we positioned directly under VATS visualization. And through that technique, we basically eliminated pleural space complications in the operative group. So 0% versus about 10% in the non-operative group. So when I counsel patients for this surgery, I bring this up as an added benefit to it. So the next question that we get asked often is, okay, I understand it's probably beneficial, but when is the best time to do it? We have severely injured polytrauma patients who might need other urgent operations. It's a Friday afternoon, and do we need to do it on Friday night, or can we wait till Saturday or Sunday, that kind of stuff. So what we found basically is it mirrored other orthopedic literature on things like hip fractures, which is that probably the optimal time to perform rib fixation, if there are no other contraindications, is within 24 to 48 hours of injury. So the way that we study this is we combine databases with 4 or 5 institutions, and Julia Coleman, one of our residents, really spearheaded this study. And we divided patients from retrospective databases into early, mid, and late time to fixation. And the early was quite early. It was less than 24 hours. The first thing that we found is that surgery is quicker if you do it in the early or mid period. And I think that people who perform a lot of rib fixation will attest to, if you get in there 5 to 7 to 10 days later, there's inflammation, there's hyperemia, there's early callus formation, and it just makes the surgery more technically difficult. The second thing that we found is that after controlling for some confounders in a regression analysis, days to surgery was associated with decreased, or I should say, quicker time to surgery was associated with a decreased likelihood of pneumonia, mechanical ventilation, and tracheostomy. So this study has been repeated by a few other groups now with similar findings, but we operate here under the contention that surgery should be performed within 1 to 2 days of injury, again, if there are no contraindications. So those were both pretty general studies, and again, didn't really hone in on specific fracture patterns, injury patterns, or patient demographics. And I think the next decade of literature in regarding rib fixation needs to focus in on specific patient populations, because what applies to a 20-year-old is probably not going to apply to a 90-year-old. And to that end, one of the studies that we recently published is this one here, which looks at the outcomes of rib fixation in patients aged 80 years or greater. And the reason we did this study is because elderly patients were traditionally excluded from prospective studies of rib fixation. And early on in my experience with rib fixation, we shied away from elderly patients because we thought the risks of the anesthetic and the tissue damage from surgery outweighed the benefits. Then we started having some more active elderly patients. I have one in mind who was 100 years old and was quite functional as a gardener, who had a flail chest, and we performed surgery and she did very well. So we used these anecdotes to pool into a study of patients age 80 or greater who underwent rib fixation. And of course, we only do 1 or 2 of those a year here, so we had to pool data across 5 or 6 centers. What we found here is our hypothesis was that rib fixation actually did improve outcomes in octogenarians and beyond. And you can see the spread of our patients in this study. Most of them were in their 80s, but we certainly had patients in their 90s and even 100 years old. And this is a forest plot here of our relative risks after controlling for confounders, showing that mortality was decreased in patients who underwent rib fixation as opposed to non-operative management. And going home on narcotics was also less likely in operative patients. Now, there was a trade-off. Patients who underwent surgery did have an increased incidence of pneumonia and stayed in the ICU in the hospital longer. We think there was probably some survivor bias here, but we certainly, or I guess we took from, one of the things we took from this study was that it's certainly not an absolute contraindication to perform rib fixation if you're older than 80 years old. So just an example of honing in on the real benefit of the surgery in different patient groups. So here's another one that comes up frequently. I mentioned before that in our non-flail study, we excluded patients with brain injury. Well, patients with brain injury can still have very severe chest wall injuries. And the question becomes, what's keeping the patient on the ventilator? Is it primarily being driven by their brain injury or their chest wall injury? So we looked at this, and this was an international multi-center study where we pooled TBI patients from many centers who underwent rib fixation versus non-operative management. And again, I mentioned this study both to highlight that it's an example of a study in a specific patient population, but also to highlight a negative study. So in this study, we found that there was no difference in our primary outcome of ventilator-free days in the patients who underwent operative versus non-operative management of their rib fractures. There was maybe a signal towards improved outcomes in very mild TBI, but in general, I believe that moderate to severe TBI remains a contraindication to rib fixation, except for very rare circumstances. And I think that's supported by this study. The final study I'll bring up has to do with a radiographic fracture pattern that has vexed me for the 10 years that I've been doing this. And I have a CAT scan of a patient who has this. And this is a fracture pattern of a clavicle fracture, a displaced scapular body fracture, and displaced posterior lateral subscapular rib fractures. So you can see here the indentation of the scapular body almost jutting into those displaced subscapular rib fractures. And one of the nice things about getting interested in chest wall injury for me has been collaborating and becoming friends with scapula orthopedic surgeons so that we can figure out the best way to tackle this problem, because this is a tremendously debilitating injury for shoulder function, particularly like an athlete, like a pitcher who would use that arm. And in general, scapula body fractures are managed non-operatively because it's a very thin bone, as you can see here, so it's hard to hold plates. But what we found is that there would be a tremendous amount of grinding of the scapula against the ribs if we didn't fix the ribs, and sometimes even if we did fix the ribs. So we looked at this in a very rudimentary way, and there's still a lot of work to be done, but Alvaro was one of our medical students who's now gone on to residency. But we basically showed that if we fixed subscapular rib fractures in the presence of a scapula body fracture, patients did not have an increased incidence of needing the plates removed or getting the plates infected. So this was our first kind of stab at showing that it might be beneficial to fix these rib fractures. The next question that is ongoing right now in another multi-center study we're doing is rib plating actually beneficial in addition to scapula body fracture plating versus not leaving the scapula alone? So I just bring this up again to highlight that there are innumerable fracture patterns, and this is a particularly vexing one that we need to figure out. Final study that I'll bring up has to do with a very broad field of local regional anesthesia and which is the best one to use in patients with chest wall injury. I have my bias towards intercostal blocks delivered at the time of surgery under VATS visualization. And here's a randomized trial that we did of that technique versus our pain pump catheters. And Chiara Licia is a former resident here who's now a categorical resident over in Miami. She headed this study up. And we basically showed that the outcomes in terms of numeric pain control and patient satisfaction were equivalent and potentially superior in the VATS nerve block group, and it was cheaper than using the indwelling catheters. So I think there are a lot of things to sort out with local regional anesthesia because there are new modalities every day in conjunction, and most of them are done by anesthesia. But what I would say is that local regional anesthesia remains severely underutilized in general in chest wall injuries. So it doesn't really matter to me which one we use. It's more important that we use something to supplement our rib fixation. So just to sum up, I believe that data continue to support early rib fixation for trauma patients with either flail chest or multiple displaced fractures and pulmonary derangements. That caveat is very important at the end. Active areas of research include the benefits of rib fixation in specific subgroups, and we need continued research to make sure that we're doing the right thing for our patients. So I mentioned the Chest Wall Injury Society a couple of times. As Dr. Schulich mentioned, I am a past president. We started out at 50 members, and we just surpassed 400 members about a month ago. And I'm very indebted to them for a lot of things, but probably the most important thing is this channel that we have where we are able to bounce difficult cases off of each other. And here's just an example of one that I put out into the Slack universe a couple months ago, and I instantly got advice from 10 or so chest wall injury experts across the country. So if anyone is thinking of joining a new society and has an interest in chest wall injury, I would highly recommend CWIS. And then finally, I would like to recognize and thank my group of trauma surgeons over here at Denver Health, many of whom are now active chest wall surgeons themselves, and I appreciate their support. So thanks so much for your attention, and if we have time, I'd be happy to answer questions. Thank you.
Yeah, we definitely have time, and the chat function is open, and panelists, feel free to jump in. But why don't I start off? Dr. Pieracci, that was a great talk. And, you know, this has really come a long way in terms of becoming more scientific, I think, in the last 10 years. And you've reviewed a lot of the articles, and I think you've participated in half of those articles. So congratulations. Now, I might have missed this, but is there a way to use pulmonary function tests or ventilator readings, mechanics, and those kind of measurements to add to when you should and when you should?
Yep. So great question. That has been studied. I'll mention one thing about the ventilator mechanics, which is that about 75% of our patients now who we perform rib fixation on never go on a ventilator outside of just getting put on one for their surgery. So we've kind of shifted our mindset to consider intubation and ventilation almost as a failure, that we should have gotten to that patient earlier to fix their ribs and get in some good local regional anesthesia. The PFT question is a good one. It's been studied at a couple institutions that are much more integrated than we are with their PFT lab and their respiratory therapists. So the kind of cheapest, most rudimentary way to do a pulmonary function test is just to do a forced vital capacity, which is what the incentive spirometer measures. But more robust PFT calculations that can be done at the bedside have been reported and have been used to screen patients for benefit of rib fixation, and also as an outcome variable to objectively show that after surgery, you've actually improved them. My personal take on it is that you probably don't need PFTs to tell that a patient is having trouble managing their rib fractures, and things like ability to cough and the classic "I'm okay unless I move" and incentive spirometry is probably enough.
Okay, thank you. I think there are two questions / comments that have popped up.
Yeah, I can see them.
Can you read them?
So,
yeah.
Absolutely.
You want to read them out just in case everyone else can't see them?
Yeah, so the first question is, was frailty a contraindicator with the 80+ population? And that's an excellent question. So certainly when you do a retrospective study of 80, 90, and 100-year-olds, there's going to be some confounding and selection bias for patients who are healthier being offered surgery versus not. So we didn't use a frailty index, which is certainly a limitation of the study. We didn't have that available to us. We tried to glean insofar as possible what the patient's functional status was from the chart, and also excluded patients who were DNR or had terminal diseases. But I think that that remains a valid criticism of that study, that we didn't really know if there was something besides the rib fixation that made the outcomes better in that group, such as frailty. So thank you for that question. And then the next question is, has anyone looked at return to work or sports in these patients? So the closest we've got to that was a quality of life questionnaire. There is a thoracic surgeon by the name of Silvana Marasco, who is in Australia, who's done a lot of return to work studies in rib fixation patients, and they've been mixed. She's found in some that patients were more likely to go back, and others that they were not. I think the general topic of how do patients do long-term after surgery remains one that is understudied. So we need to know more about that, but there's no real huge signal that we're getting patients back to work earlier with the surgery.
Okay, well, Dr. Pieracci, thank you so much for sharing that with us, and congratulations. I think this is an example of a surgeon who focuses on an area, studies it clinically, writes papers about it and trains people based on these operations. And really that I think is the hallmark of a great academic surgeon. So thank you.
Thank you.